Dr. Leigh and Mike, thank you so much for presenting our echo didactic today. We, for those of you who have been on echo before, Dr. Mike might be familiar. She is one of our echo panelists and is a pharmacist. She's an associate professor in the School of Pharmacy and also an assistant director in the Klein Center, and does a lot of work in geriatrics education in the School of Pharmacy and has a lot of experience in this work. And we are hearing a very special talk because Dr. Mike gave a very similar presentation at last week's American Geriatric Society National Meeting. And so we're lucky enough to have you here to speak to us, and we can get all of our questions answered that we might have. So thank you so much for taking the time today to talk to us.
Thank you. It's my pleasure. Thank you, everybody. Could you please confirm that you can see my screen?
Yeah, it looks great.
Okay, thank you. Okay, so yes, it's my pleasure to present to you like really hot off the presses. I did present this just a week ago, almost to the hour, at the American Geriatric Society. It's been modified a little bit to fit the time, the shorter time allotment, but happy to take any questions as we go throughout. And my focus is going to be on learning more about the hidden risks of medications. And the focus is primarily for this session, talking about dosage formulations. So my goals for the session are to talk a little bit about the implications that include adverse effects of various medication formulations that are used in older adult patients. And ultimately, I'm hoping that at the end of the session, you'll have 1 or 2 action items that you can incorporate into your own practice starting tomorrow, or if you're like going into the clinic later today, maybe you could even start it today. So Dr. Bennett has asked me to frame this in terms of the 4 M's, and that was really not too difficult since it fits into the medication category. So strictly talking about medications today. So I wanted to start off with sort of a mantra, a tenet of geriatric pharmacotherapy, just to kind of frame our discussion today. And that's that any symptom in an older patient should be considered a drug side effect until proven otherwise. I'm sure we've all heard that before. We probably have that in our mind as we're practicing. So I want to go into the session with that sort of in the forefront. And as we kind of move into the main content in terms of like medication formulations, I wanted to talk just a minute about pharmaceutical sciences. And part of the reason I wanted to talk about this is to draw the distinction between the pharmaceutical sciences and pharmacy practice. There are many people, including people in my own family, who think I am a pharmaceutical scientist. And based on the definition here, I sort of am, but I also wanted to call out there are a large area of research in the pharmaceutical sciences that goes beyond pharmacy practice. And those the things that are involved in pharmaceutical sciences include drug discovery, drug development, drug manufacture, and safe use. So it's pretty large field of study. And I know any other pharmacists on here on this call would remember in part of our training, we did a little bit of manufacturing on a really small scale, but really the pharmaceutical sciences is much larger than that. And for the purposes of our discussion today, I want to focus primarily on medication formulations. So you might also recognize dosage form as a formulation. I may be using those words interchangeably. So what is the final drug product or dosage form that the patient is going to be taking? And we'll be talking about the hidden risks in those. So what's the function or purpose of dosage forms, or also known as the drug product? Well, many times, not many times, all of the time, the dosage form is related to its route of administration. So what we're looking at is, a certain formulation is made to make a product intravenous or subcutaneous or intranasal. So the dosage form is tied to the route of administration. And the dosage form, when we're choosing the best dosage form, the rationale behind that is we want to choose something that gets adequate bioavailability and exposure. So we want it to get to the site of action in the patient's body so that it can have its intended pharmacologic effect. Also, dosage forms are created in a way that can facilitate adherence and also facilitate ease of administration. And so just some examples, I think, from the just a marvel of pharmaceutical sciences and advancement is that if we think just as a way of managing symptoms of Parkinson's disease in terms of just dosage forms or drug products, look at the wide range of pharmaceuticals that are available to us to help patients with symptoms of Parkinson's. So there's oral, subcutaneous, transdermal, intrajejunal, which is a relatively new route of administration, and then buccal, which means in the cheek or inhaled. So I use this as an example to show you the wide variety and range of dosage forms that are available to us that help us achieve the intended effect and the adherence and facilitation on the right side. For the purpose of this talk, though, I do want to talk about what are considered modified release products. And I want to focus primarily on oral just because that is the most commonly used dosage form that most people are familiar with. And examples of the modified release oral products that I'm talking about today are the extended release, the long acting, or delayed, sustained, or controlled release. So they're forms modified in a way that it modifies the release of the drug in the patient's body. So in terms of modified release forms, since we're talking about the risks of medications, the most obvious risk is tied to what happens if you change a modified dosage form. So for example, by crushing it, which is something that we need to do. I think I learned a lot about crushing medications in my work in the intensive care unit. Not everybody could swallow tablets. So a lot of this comes from my own personal experience of figuring out how to get drugs into patients. So what happens if you crush a medication before you administer it? Well, the patient can experience a dose dumping effect. So essentially a whole day's worth of medication can be released at one time. And there are case reports of people experiencing overdose because of this dose dumping effect. Medication errors can happen. Unpredictable response to the medication could happen because you're changing the way the medication is released in the body. It can become non-palatable, and so patients less likely to want to adhere to it. The dose administered could be incorrect. And there's also a risk to those handling the medication. So I'm hoping that will give you a different spin for today, that it's not just the patient who's at risk for some of these medication-related formulation problems, but also people handling the medication. And then, just as a reminder, when we are using modified release products, we want that to be extended over a period of time, whether it's every 12 hours or once a day. So we don't want to alter that, or the patient could experience these adverse events or effects. So you may be asking, well, how many people are actually crushing their modified release dosage products? And I found a couple of studies that help us answer the question. The two that I've selected for today to share with you, the first study, the Sheila study, was done in Germany. And what was really striking to me is that more than half of patients in that study with swallowing difficulty modified their medications in some way. That was either by crushing, opening capsules, and mixing with food or liquids. Now, do we know exactly how many of those that were crushed or opened were modified release? I don't know that, but if we can just extrapolate that any of them, there's a lot of people who are modifying their dosage forms before administration. The second study, the Godart study, is a French study. It's relatively more current, or more recent rather. And almost 20% of the patients who took more than one medication were modifying it in some way. What I found interesting about this one is that it was the caregivers who were most likely to alter medications. It wasn't the patient, and it wasn't a nurse or somebody else helping, a health professional who was helping with administering a medication. It was caregivers. The thing that struck me as a pharmacist and worried me the most is that many people weren't aware of the risks of modifying the dosage form. So all of the things that I just shared on the last slide. So they were doing it as a way of being adherent to the medication, making their products, making their medication work, trying to figure out a solution, even if they might have had some challenges with swallowing. And then like the most concerning thing to me is that those modifications that were done were not very often discussed with either the prescriber or the pharmacist. So, there are some people out there trying to make their medications work for them, and they're doing things to it that may be unsafe and may not be telling us about it so we can help them find a better solution. Why were they modifying the medications? Many of them said that they were having trouble swallowing the medications. And one of the things that I found interesting is that a few of the respondents didn't really attribute their difficulty swallowing with the swallowing. It was more about the medication. So they attributed the problem swallowing with medication rather than inherently having a challenge with swallowing. The people who responded to the survey also talked about pill size or surface, shape, or flavor as contributing factors. But really, I think for me, one of the biggest takeaways is that when people were having trouble swallowing, they didn't recognize that as dysphagia. They thought it was about the medication. So takeaway for us. So, sometimes we do need to crush medications to help people with swallowing challenges. So I wanted to include this information as a way to help us make safe decisions. So here's a guidance table that you can use. There's some guidances from different countries like Australia, the UK, United States. Some of you may remember the ISMP, the Institute for Safe Medication Practice, do not crush list. Well, that went away within the last couple of years. They decided to stop updating and publishing that. So that actually doesn't exist anymore. If you go to the website, they're like, sorry, we don't do this list anymore. But the good news is that the pharmacist letter has taken over a do not crush list. Now, just one word of warning, this do not crush list is not all inclusive, but they are building it over time. So if you're really looking for something like that, you can just type in your browser, pharmacist letter, do not crush, and it will take you to a document that at least help get you started. But there are, on this table, there are other guidance documents on how to manage crushing medications if this is something that your patient needs to do to manage their medications. All right, so now I'm going to switch gears a little bit and talk about not just risk to patients with modifying dosage forms, but there's also risk to the people who are handling the drugs. And there's actually a pretty serious guidance from NIOSH, and they keep together a pretty comprehensive, many page document on how to handle anti-neoplastic medications and other hazardous drugs. And many health systems have policies and procedures in place to protect the handlers of these medications, but this is likely not happening in a community-based setting. So what are the risks of altering hazardous drugs, like crushing those? So there could be certain things that are either acute or chronic, like something like a skin rash. But there's a few more that are, a lot more serious in terms of like adverse reproductive outcomes, whether it's infertility, pregnancy loss, congenital malformations. And there's also some possibility that these hazardous drugs may be linked with leukemia or other cancers. And remember, this is the focus of these hazardous drugs is people handling the drugs, not the patient who may be prescribed and taking the medications. So those people at risk are those who handle or administer it. So that includes us as healthcare workers. This could include caregivers out in the community. It could include environmental service workers who are like cleaning up spaces. I mean, there's actually a longer list of people who are at risk, and those are all included in the NIOSH. But really, like I said, health systems have safeguards in place to protect people handling hazardous medications, but this probably is not happening in the community. So I'm bringing this to you so you can at least be aware and potentially educate your patients and caregivers if they are taking a hazardous medication and are having trouble swallowing. So, okay, so what are some medications that are considered hazardous? On this slide, there are three big categories. There are the anti-neoplastics. There are anti-neoplastics that have one or more criteria, a non-anti-neoplastic that has one or more criteria for hazardous drug, or drugs that pose primarily a reproductive risk to those who are trying to conceive or those who are pregnant or breastfeeding. And within the slide, you can see like common medications that we use in older adults are on this list. So something like warfarin. And, you know, if you are prescribing warfarin for a person of childbearing age, you would see that we're going to avoid that. There's a teratogenic risk, but you may not always think about that in older adult population, but handling medications could cause risk as well. So important to recognize that avoiding crushing is important when educating caregivers and others who are helping family members. And then some recommendations include using gloves when handling medications. So help keep the folks around the patient safe as well. So let's wrap up. So some action items. I'm hoping that you can take away a couple of things to incorporate into your practice today. So first takeaway action item, make sure you're asking about swallowing difficulties with medications. So ask if your patient is having trouble swallowing medications. If they say yes, you may consider referring to a speech language pathologist. You may also, kind of skipping down the list, explore alternative dosage forms, explore different shapes or of solid dosage forms, whether it might be a capsule versus a tablet, something like that. So there may be some options around that, but we won't know unless we ask. Additionally, you can ask how patients are taking medications, which we kind of do anyway. But I think we mean that in terms of like, what schedule are you using? But really thinking about, are you having to crush, or how are you preparing medications for administration? That could be another prompting question. Are you opening capsules? What are you doing? You know, are you putting on a pudding? Whatever that might be. And then lastly is recognizing that there may be more altering of medications in a community setting. So providing additional education about the risks, about altering them. And that includes risk to not just the patient, but also the caregiver. So in summary, altering medication formulations can result in adverse events for patient and potentially the caregiver. So let's not forget about them. And then, you know, if you add this to your differential or your thought process or your workup of patients, recognizing and assessing these hidden risks of medications can potentially even improve patient outcomes. And so my bookend, we started off with this quote. I want to circle back to it again. And this time I want to add my own little addition, which is that any symptom in an older patient should be considered a drug side effect or a drug formulation effect until proved otherwise. And with that, thank you very much for your attention. I'm happy to take any questions.